our December 2025 Durham County Board of Health meeting. Hopefully everyone has had an opportunity to look over the agenda. And if that is the case, I will entertain a motion to accept the agenda that has been published.
So moved. This is Pam.
All right. Thank you, Dr. Silberman. Do we have a second? All right. It's been properly moved and seconded. Do we have any debate? If not, we'll entertain them, or we'll entertain the vote.
Okay, Dr. Glover. I'm sorry, Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Dr. Glover, Mr. Gregorio, Dr. Jackson, Dr. Miller,
Yes.
Dr. Orto, Dr. Silberman,
Yes.
Commissioner Valentine, and Dr. Verbeest.
Okay. All right. Now before I go on to the next agenda item, I had difficulty opening or accessing the link for the minutes for the October meeting.
Yeah, they kept backfiring on me. Every time I sent them out, the mailboxes were full. So I had to try and resend them. So I sent them by link.
Was anybody else able to open that link? You were, Dr. Silberman? Okay. I wasn't able to get that open. So if the majority of the board was not able to do that, maybe we should table that for our next meeting. If you don't mind sending that out again for us, Donna.
Okay, I will send.
Did anybody else other than Dr. Silberman, were you able to open or review the minutes for the October meeting?
I was not
Dr.
able
Miller.
to. Yeah, it kept giving me a rejection.
Yeah,
Okay.
a lot of the emails bounced back to me. I
So,
think
yeah,
the file was too big.
Gotcha. So we'll try it, and we'll table the review and acceptance of the October meeting minutes until our February meeting.
Okay.
All right. Do I need a motion for that? I don't. No. Okay. Thank you. All right. So we're on to our public comments. Donna, we received any requests for public comments?
No, we did not.
Very good. Thank you. So we're moving on with our staff and program recognitions. Dr. Jenkins, you have the floor, sir.
Thank you so much, and good evening to this illustrious board. Wish you all, you and yours, happy holidays. I will say we're going to do our recognition a little bit differently, but as far as staff recognition, I certainly want to recognize Ms. Bria Miller, who you may have heard was selected to be one of the Beaumont Foundation's 40 under 40. We've done the very best that we can to really laud and applaud her for many, many months. I told her I was going to show her off as long as I could, but we are certainly happy that she was selected. She does a lot of great work as our coordinator for the Partnership for a Healthy Durham. So, again, hats off to Bria. I'd also, where it's going to be a little different, in her absence, I know Dr. Verbeest is, I think, either in Japan or on her way from Japan, doing what she does best, which is championing maternal child health issues through social work. But last month at the American Public Health Association, she was awarded a very prestigious honor. That was the Outstanding Leadership and Advocacy Award from the American Public Health Association's Maternal and Child Health section. So again, I just wanted to really, in her absence, just wanted to really lift her up and just say congratulations to her for a job well done, many, many years in the field, and continue to have that fire going for these issues that are so near and dear to the work that we do in public health. Last but not least, on behalf of a very, very grateful agency, we know those salutations and everything's going to come to the end, but I'd be remiss if I did not say thank you to Dr. Roger McDougall. This is his last meeting as board chair and being on the board. I just want to personally say thank you for all the encouragement and all the support that you've given to me over the years. You have been present not only from perspective as a member of the Men's Health Council, but you've come around and come through the different agencies, the different departments, I should say, at the health department, and have always been well received by staff. So, Dr. McDougall, we owe you a debt that we'll never be able to repay. But we just want to say thank you for your years of leadership to the Durham County Department of Public Health's Board of Health.
Well,
Well, I got
let me start by saying thank you for that recognition. It's certainly not necessary. I've enjoyed it so much, and it's bittersweet that this is my last meeting, but I know I'm leaving it in capable hands with our current vice chair, and not to mention our very capable director and the entire staff. So it's been a pleasure, though. And I want to also echo the congratulations to Bria Miller and to Dr. Verbees for all the great work that they're doing on behalf of, at least in part, of the Durham Department of Health. So thank you. All right, so we're going to move on with our administrative reports and presentations. We have our roles and responsibility training this evening, and I see Ms. Levette here with us, ready to update us on all that we need to know regarding roles and responsibilities. So
yes, thank
you have the
you.
floor. Yes, ma'am.
Thank you so much. I'm glad to be here and so glad to really be back here. I joined you under technical difficulties last time, and I'm kind of determined to try not to have that happen this time. So I'm gonna see how this goes. Let's see, Donna, can you see my screen yet?
We can't see your screen yet, but you
Not
should
yet.
you have host capabilities.
Okay.
And if you need us to, our team can go ahead and flip your screens for you.
Let's see, let me get down. I think I got it. Let's see. And now I'm going to put this presentation up.
We can see it. Just needs to be larger.
Okay, great. Let's see. Okay. So we're going to get started here, and you're going to get.
You may just want to put it in presentation mode if you can.
Okay. You know that I can. I practiced this before I got on.
Of course you can.
Yeah. Maybe I can. Let me escape really quick. Don't you hate this part? I'm apologizing except for this.
You're good. If you go back there to where you had it, and then click on display settings.
It's oh, I got it. I had something hiding from me. Yeah. Okay. Now is that working?
There we go.
Perfect.
Okay.
Yeah, perfect.
Yeah, just had the Zoom instructions hiding from me. But anyway, thank you for letting me be here tonight. The slide deck that's provided by UNC School of Public Health, the Institute of Public Health, is really big. Donna sent you the link to the whole thing. I've abbreviated the slides for tonight. I do recognize that we have a very experienced Board of Health here, and I can tell Dr. McDougall, they're going to really miss you, but how good y'all make Rod Jenkins look, and vice versa. I think such a phenomenal public health department there in Durham County. So I'm going to zip through here fairly quickly. I welcome any questions, and so stop me if you have any. But we're going to roll here. One thing we were talking as I logged on is a lot of things haven't changed a lot. And I'm reminded that the reason we're still showing this picture of these general statutes for the local boards of health and the kind of the same learning objectives is that when we work in this field, which is governmental public health, especially in climates that are kind of polarized, when we work in public health, we recognize that sometimes keeping old laws that we would love to update or tweak a little bit is actually safer than opening laws up to get something a little bit more right and running the risk of having elected officials without the expertise that we hope that all of the elected officials have, really changing things. And so we do have some dated general statutes and public health rules, but they are probably among the best in the country still. And that in part is because of a really smart public health leadership at the state level, at the university levels, and at the local level to make sure that we keep those laws intact. So we've got these 4 objectives here, and we're hoping to help you, probably remind you mostly of these objectives of your role as a Board of Health member for Durham County Public Health. And so we'll roll right into section 1. Again, I've abbreviated it. You are not just a county board of health, but a very strong county board of health. I noted that in the annual report, your county funding is a little more than half of the total funding of the Durham County Public Health Department, and that is really strong. It stabilizes a public health department during times of federal and state budget issues. We talked about that briefly as we signed on as well. And so congratulations to you all, because it takes your advocacy and the commitment of your Board of County Commissioners to be involved and listening and engaged with the work that you do. So I think that most of you all know the overall the big ticket items that we do in governmental public health. So I'm not going to read them to you. We've definitely experienced and practiced some of these more than we ever wanted to in the last few years, as local health departments have responded to infectious disease, increased environmental hazards, and challenges with having adequate direct service for the people, all the people of North Carolina, all the people of Durham County. It is the public health is really our organized community efforts aimed at the prevention of disease and promotion of health. You can see these pictures when I was a youngster in public health. I think most of the folks that I talked to thought that public health was health care for poor people at the public health department. And while that is still critical, we know that really making a healthier community is the most important thing that we can all work together on. And so we work in public health on prevention of disease, promotion of health. You worked on your community health assessment to understand the issues that you have and at the local level. And yet still, our greatest accomplishments of the 20th century remain the same. They surprise some. And unfortunately, some of these are under fire. So one of the things that's listed toward the end of this presentation is your role as a Board of Health member in advocacy for the public's health in the space that you have influence. So when I worked in the mountains, Appalachia District Health Department, I was had a county, Allegheny County, that was one of the first in the states to remove fluoride from drinking water. Imagine my dismay. It has not been returned to the public drinking water supply yet in Allegheny County. So these are things that a lot of us take for granted, perhaps, but they need your help to remain viable in our current world. So additional public health achievements that you may not always think about are in cancer, advocating for screenings, providing screenings, childhood lead poisoning prevention, and public health preparedness and response. So we continue to have our challenges of integrating physical activity into daily lives, really working on the environment, reducing violence, and health equity. Now, I thought it was interesting that I was happily I'll say happily aware that this presentation has not changed to remove the things that we know are important in public health, which is understanding health equity and working to think through meeting people where they are in terms of being able to impact the health of the public. So those haven't changed. I always think of these points. Our main goals are to prevent disease and promote health. We've always talked about how it's hard to put a price tag on prevention. Great public health achievements, in spite of some of the things we hear, they do include vaccination of the majority of the population, working for healthier mothers and healthier babies. And yes, even seat belts and helmets are public health laws that remain on the books here in North Carolina. So how does the governing board fit into the big picture? If you've been in any public health presentation in the last 15 years, you've seen this circle of the core functions of public health, which do with equity at the center, assessment, policy development, and assurance. These are the core functions of governmental public health. And it's not that the Durham County Public Health Department Department of Public Health is supposed to do all of these things, but the leadership of the county health department and its board of health are supposed to evaluate and assure and take action where possible on all of these things, which is really, it's really a tremendous amount of responsibility. Some authority, but it's just so big that I think when you are talking to people about the work that you do on the Board of Health, anytime you get a chance to make it real for someone who doesn't have the familiarity that you do with governmental public health, it's helpful to think about this big picture and then drive it down into a smaller picture that can be understandable for the person that you're chatting with. I'm a big supporter of talking about the work of public health wherever you are, at church, at mahjong, at your professional meetings. It's just so important to keep the conversation alive. Community health assessments are a big part of how we get this big, broad job of public health into bite-sized and more manageable pieces. So I've looked at your community health assessment priorities, and I thought, how cool is this? Your the number one priority is affordable housing. And kudos to you, a board and a leadership team that gets how housing first really is a critical health support in our state and in our communities. Access to health care and health insurance comes second. Are y'all like me? Sometimes I cringe when I hear our government folks talk about it, and they talk about health care and health insurance as if they are exactly the same. So I love that in your priorities, you acknowledge that health care and health insurance are not the same. In our country, both are pretty darn important. And so that's the second priority that you all had. Community safety and well-being, mental health, physical activity, and nutrition and food access wrap up your community health assessment. And it's easy to find it on your website, which is another kind of way to go. So those kinds of assessments, these leadership reports that Rod brings to you, when other people in the department report to the Board of Health, so you can get a feel for the entire leadership team of the board. Those are the kinds of things that I think help the Board of Health really assess not just the health of the community, but also the health of the health department to figure out how to make things happen in Durham. So you know that you have authority to make, you actually have to have an operations and management policy. That's an accreditation requirement. But the policy is limited by state laws and county ordinance and policies. You may have board operating procedures, probably do. And I would expect you have a board approved strategic plan. Is that, I didn't look for that, Rod, but is that, no? Mm-mm. So that's just an example and not necessary, not required, I mean. I think it's important, of course, for you all to kind of know where you are, where you've been, and where you're going. And I think, Rod, I've watched you and can see that you've got that well in hand.
Beth, let me make sure I correct myself. We do have a strategic plan that has been vetted by the Board of Health, so I do apologize for that mistake.
Okay, good, good. I think that's great. I think that's a part of the role, but I was going to roll with it and talk to you later. So assurance, this is something that can be a little complicated because public health departments, governmental public health departments are required actually to work to assure that public health services are provided, even when you're not providing them directly. And that can really be complicated in the world of, most physician offices working under the umbrella of a larger organization. So it's complicated, the world that we're living in. But I do remember working with Rod, and I know we aren't thinking about COVID as much as we used to, and aren't thinking about it. But the lessons that we learned there and the relationships that were built remain. And I remember working with Rod and his hospital partners and community health partners. And so that's a part of this assurance model, and engagement equals influence. So keep that good work up. Your board responsibilities include working with Rod, lifting something up that you are concerned about that may or may not or turn out to be a big deal can be really important. The Board of Health is in the community in different spaces than the public health director and the staff at the public health department might be. And so having your ears out there can be very helpful to identify trends and to assure that you have that collaborative effort, and also your influence in terms of when it's budget time to assure that you've got the resources and infrastructure needed. So we've talked about those 3 core functions of public health, the 10 essential services, and the services that represent these aspects, crucial aspects of your board. I'm rolling toward the end here. Legal authority for public health, these statutes remain on the books. I'm not going to read them to you, but they are critical, and they are among the public health statutes that make North Carolina's Association of Local Health Directors one of the strongest in the country. So nice to be aware of that. You can look them up online. You don't have to have that big green book anymore, but you can look them up online. We also have we're responsible for following administrative code, federal law, local rules and ordinances, of course, court decisions, and then any contracts that the health department is engaged in. So how does it work together? I did grab these pictures off your website, because actually off your Facebook page, because I wanted to give a little shout out for how active your Facebook page is. So whoever does your social media, Rod, and your press releases, probably not the same people, but maybe, great work. And I loved your December message. And Rod, do you do that every month, or how often are you on Facebook with the whole video thing?
First of all, that army is one person. That's Dr. Alicia Smith, our PIO. She's awesome.
She is.
She gets kudos from North Carolina all the way to California.
That's just great.
People seek me out and they say your Facebook page and your posts are really good. So shout out to her. But she's the one who has me on Facebook more than I care to be.
Well, I thought I was just really impressed, and I'll talk to you offline sometime about, did you have a teleprompter? I mean, you were doing a great job. So we've already talked about these state laws that require essential services, mandated services, where local health departments, have to meet accreditation priorities. But that is currently unfunded, I think, still. Is that right, Rod? Yeah. have to meet the requirements of the consolidated agreement, which is the contract sort of between local health departments and the Division of Public Health, and of course, federal laws. We've already talked about this. I wanted to mention this, that the 10 essential service model is from 1994. There's actually been at least one more essential service added, but our state law has not caught up with that. And that one reason is this feeling that if we open up General Statute 130, what might get done to it with the marking out and added in. So we're hanging in there pretty well with this 10 essential service model. That talks about the the laws. So these are on my left-hand side, provide. These are the things that are written into general statutes that say health departments have to provide directly or by contract. And then on the right-hand side, you see local health departments are still required to provide or insure. This again is a little dated. Back in the day, home health really was born in local health departments, then went under the management of hospitals in a lot of places. From there, it's being mostly managed by specialist companies under contract with hospitals. So this is not quite as crisp as we would like it to have, but it's what we have. We've talked about accreditation briefly. I'm a big advocate of accreditation. I think it standardizes kind of a baseline between all 100 counties and their health departments. It isn't necessarily it's not the end all be all. I'll just say that. But if we did not have it, coming from my last job at the state, let me promise you, the differences between a small health department in North Carolina and a large one would be devastating to the communities. So having this baseline of accreditation is really critical to the folks of North Carolina and all 100 counties. The consolidated agreement, I like to say this because I learned when I worked at the state how little state dollars come to local health departments. Almost all of the money that comes through this consolidated agreement to local health departments is federal. They're federal dollars. They include a state match in some cases, but they are terribly cumbersome with programmatic and administrative requirements, most of which trickle down. And so it was one of those dreams I had to make it a lot more streamlined when I was working in Raleigh. And I have to say, we worked hard on it and maybe made a few improvements, but we really couldn't get where we wanted to be with that. So these federal laws, I'm going to go right through. These say subject to change. I mean, they are really subject, really changing under our feet right now. So we will watch and wait on how federal laws continue to impact state and local delivery of public health. I promise I'm wrapping up. Your Rod and his leadership team are your administrators of public health. Within public health, there are things that must be enforced. The local health departments really have a good grasp of this, and they run smoothly through investigation of communicable diseases, quarantine, isolation, sometimes things like restaurant, things that you have to enforce at the level of restaurant inspections, et cetera. The public health department is also an educator and can be a liaison for the public to the public health officials or to the government officials that have authority and responsibility. But the local board really should have the big picture of public health and the big responsibility to protect and promote the public health. I'm going to skim through Board of Health rules. There are a lot of requirements. There are very few health departments with local Board of Health rules still in place. If you needed them, you would need a lot of expertise and a lot of discussion with an attorney or multiple attorneys at the state level. But some jurisdictions may still have some rules that govern private drinking water wells, mosquito control. And a Board of Health rule may be more stringent than a commission rule, but it cannot be less stringent. So these are your limitations for Board of Health rules. And these are additional limitations. So smoking, I was pretty sad when the smoking rules had additional limitations added. Board of Healths are sometimes called in for adjudication. There again, I'm not going to cover that. It's really specialized if that happens. In the time that I was a local health director for 25 years, I did not ever have to take anything to the Board of Health for adjudication. And briefly, this covers fees and the budget, which Rod and his team would be putting together for you. This just reminds you that county health departments, the Board of County Commissioners still must approve the Durham County Department of Public Health budget. So these are what we hope you'll do. Educate yourself about all of this, share broadly, attend meetings, review meeting materials, carry out any assignments, participate in open dialogue, represent for Durham County Department of Public Health, work to make the links in the community and act as an advocate. Dr. McDougall, you're signing off on this, but I've witnessed your wonderful chair abilities, and thank you for that. And I can't remember who's the vice chair. Are they ready?
Dr. Ray. Oh, he's ready. Absolutely.
Dr. Ray, are you ready for this?
As ready as I can be.
I think you've really got a great team to work with. And so you do have to do an annual evaluation of your health director, and would normally work with the health director to set the meeting agenda, counsel, and consult as needed. And heaven forbid you need to remove a board member, but there are rules for that. And Donna and Rod are experts in the guidelines for the board meetings and activities, open meeting law, etc. So we encourage you all to be involved in the big picture stuff, leave the day-to-day operation of the health department to the health director, and work to develop as needed, but definitely support policies designed to promote and protect the public's health. So here's our partnership compass. Here's our, I think they're kind of a check mark for governing well. And the commitments that we ask that you make together. These are, I'm not going to read them to you, but they're really a great list to just remind yourself, not just on the Board of Health, but on any board. Shared involvement is key. So I think the last thing that I wanted to say is I serve now on nonprofit boards. I do not serve on a governmental board, but I feel like it is a privilege to serve. And if it's too easy, then think about, are you doing it right? Are you reading the materials? Are you engaged and asking the right questions? So thank you. I think it's what I'll wrap up with. I'll take any questions if you have any. Dr. Jenkins, if you get any after the meeting, anything that you would like me to follow up with, I certainly have access to a whole lot of resources, and I'm glad to do that. But let me pause now just to see if there are any questions. All right. Well, I think you're free. You're not free to go, but I might be.
Well, thank you, Beth.
I'd just be remiss if I didn't say to this group that it is grand to see someone as tenured and as on fire for public health as Beth Lovett. She's retired, but she's still in the fire and in the fight. And it's amazing when you just hear somebody's voice and you know exactly who it is. And that's Beth.
Same. lots of phone calls.
Indeed.
But thank you. It's a pleasure to be here, and happy to do it, and happy to come back and do it whenever you need me to. And I'm also happy to take it down to any kind of a micro level that you feel like your board might benefit from.
Right. Mr.
All
Chair.
right.
Certainly appreciate it. Thank you. Thank
Thank
you so
you.
much, Beth. All right. And we did open the floor or extend the floor to questions, and we didn't have any. So we'll move on. Thank you again, Beth. We appreciate it. Our next agenda item is our fiscal year 25-26 first quarter fiscal update from Micah Gwendon. So Micah, you've got the stage one more time this year. So
Yes. Thank you so
floor is
much.
yours. Yes, ma'am.
Thank you, board members, for having me. Always happy to be with you. And yeah, hope everybody is well. I've got 8 slides this evening. Always grateful for the opportunity to share. Tonight, we're going to be talking about quarter 1, which is well in the rear view at this point. But due to our meeting schedule, this is our first opportunity to talk about quarter 1. So we started our fiscal year with a budget of $28,410,835. We have moved $170,776 into the budget via amendments and rollovers. So our current budget is $28,581,611. Our expense budget is about $40 million, excluding the benefits that the county keeps in a separate space. 40 million is a 1.11% increase from where we started the year. And we've spent $7,076,078, or 18% of that general fund expense budget through quarter 1. That is lower than we spend usually in a quarter, but this quarter 1 number is indicative of our contracts getting in place. And as you all know, we spend a lot of money on contract services. Takes a while for those to get executed, invoiced, and then paid out in the beginning of the year. So that's why that's a little bit lower than what may be typical. Our personnel costs totaled $5,943,442. And contract spending, as you'll see here, you all are used to at this point, those two being our highest. And this is representing that little lower number, $890,735. Some specific purchases from quarter 1. We spent $46,332 on Narcan nasal spray. We spent $19,909 on dental supplies to get the year kicked off, as well as $16,747 on various vaccines for the immunization clinic. One thing that I wanted to note for you all is that this year, notable on our expense side of things, the county decided to move the activity of payments of the medical examiner into public health's budget. So that new cost center has been added to public health's portfolio, and it approximates about $443,401 in contract services. We have brought in $2,014,931 in revenue as of quarter 1, which makes up 18% of our revenue budget. $928,408 are from Medicaid. Grant revenue is $847,231. Those two make up 88% of our revenue, which is what is typical for us. We've got $142,326 in service fees, which includes, of course, patient self-paying as well as environmental health activity. Last but not least, we, as you all know, continue our opioid projects. We've got 3 of those, And for this fiscal year, 25-26, we have $937,000 budgeted for those 3 projects. At the end of Q1, we've spent 13% of those budgeted expenses, and that our contract line, just my kind of main tagline this evening was, we have a fairly large contracts in this area, and those were not executed fully at the time. We'll expect to see those increase as we get caught up and things getting logged in. Already seeing that at this point. So I always appreciate and thank each of you for your attention to the fiscal matters, and happy to take any questions that anybody may have for me this evening.
All right. Anthony Gregorio is not here tonight. He's usually
Oh, I miss him. You can imagine.
Yeah, he's our numbers guy on the board. So,
Yeah.
but always a great presentation, Michael. We appreciate you. So thank you
Absolutely.
so
Thank
much.
you.
All right. I guess our final presentation for the evening is our 2025 Communicable Disease Report by Dr. Jenks. We haven't heard from you in a few months, so we're looking forward to tonight's presentation.
It's been a
Dr.
minute.
Jenks.
Yeah. Thank you for having me. I can't guarantee I'm going to go as quickly as Micah did, but I will try to move us through this. Let me know when you can see the slides in their presenter mode.
Not in presenter mode yet.
Not yet. Okay. Get this. Here we go. Is that better now?
Yes, sir.
Okay, great. Well, thanks again for having me this evening.
Hey, Jeff, you just need to swap it out, like in that display.
Make a
So it
little
didn't
larger.
swap out?
Ah,
Okay. Is that better?
Perfection.
there we go.
Okay. We'll go back to the title slide. This is a few of the communicable disease team on Halloween. We were Gru and the Minions. For some reason, this is timed and switching. So we're gonna, as with other CD presentations, this is gonna be a bit of a 30,000-foot view presentation. So we'll move pretty quickly through these. So we'll talk about sexually transmitted infections, and then hit some of the other non-STI communicable diseases. And then end just with a really brief update on where we are as far as flu, RSV, and COVID this fall. So this is a similar slide as previous years, but just to remind you, so most of the data here was pulled from the North Carolina Electronic Disease Surveillance System. Savannah Carrico, our epidemiologist, pulled most of this data on November 19th. The HIV data is always a bit delayed, so we'll get 2025 numbers sometime mid next year. So don't have any 2025 numbers for you as far as HIV. And then there was a bit of a delay as far as our tuberculosis data making its way into NCED. So our data scientist, JP Zita, pulled that from EPIC. But most of this comes from NCEDs. Going to present a five-year data span. And as always, some of this data may differ from what's on the state website, just based on kind of when the data is put in and where it's at as far as the cleaning process. We're kind of jumping right into it. So chlamydia, we've got some success stories, which I'll touch on primarily in the beginning. So we've got, we have seen the past 2 years decrease in chlamydia infections in Durham County, and that mirrors what we've seen nationwide, where there was a 8% decrease in chlamydia infections from 2023 to 2024. No nationwide data yet for 2025, but I'll be interested, and I'm expecting that we'll see lower chlamydia numbers nationwide as well. As usual, people who identify as female, Black, or African American, and those who fall within that 18 to 29 age cohort are overrepresented as far as chlamydia infections. And on the left, you can see kind of the trend up till October in the figure in that gray kind of dotted line. Similarly, we've seen a decrease in gonorrhea infections as well, as though there was I think a 10% drop nationwide from 2023 to 2024. Again, like with chlamydia, expecting probably a drop in 2025, which is what would mirror our findings here in Durham County. As always, gonorrhea is overrepresented in people who identify as male, Black or African American in that same age cohort, 18 to 29-year-olds. We tend to see the most cases in that age cohort. And again, you can see that in the figure, the gray dotted line is our trend through October. Primary syphilis, we've also seen, for the most part, a decrease in cases. You can see in the figure, it's blue dotted line with primary syphilis, but have seen a drop. There was also has been a decrease in primary syphilis cases nationwide in 2023 to 2024. Again, primary syphilis tends to be overrepresented in males, people who identify as Black or African American in that same age cohort as we see with chlamydia and gonorrhea. Primary syphilis is the kind of the first stage of syphilis infection. Most people, not everyone, but most people will get a painless sore or a slightly painful sore at the site of exposure, and that sore will typically go away within a couple weeks with or without treatment. Secondary syphilis, that's the second stage of syphilis infection. Not everyone gets this, but most people will. It's typically a painless, itchy rash on most of the body, and that again will go away with or without treatment. We've seen a decrease in secondary syphilis infections as well, which mirrors what was seen in 2023 to 2024 nationally. And again, males, people who identify as male, Black or African American, and those in that 18 to 29-year age cohort are overrepresented. So latent syphilis would be categorized as someone who has no signs or symptoms of syphilis infection. So that would typically occur if we don't catch them when they have primary or secondary syphilis. The syphilis is still in the body, it's just not causing symptoms. Early syphilis would be if we can determine they were exposed within the previous year. Latent syphilis would be if we don't know or we think they were exposed greater than a year previously. And again, males, people who identify as male, Black or African American are overrepresented. And primarily with that latent syphilis stage, we tend to see people who are older. There have been decreases in early latent syphilis. We're not really seeing a decrease in latent syphilis. And again, that's primarily because we're not testing everyone. We're testing people in the younger age cohorts, but not the older age cohorts where there's still quite a bit of a latent syphilis because they've not been tested. Here's our congenital syphilis numbers over the previous 5 years. They continue to be low with a caveat. My suspicion, and this has been true in other parts of the country, that these cases are being underreported. So our actual numbers probably are a bit higher. HIV, frustratingly, we've not been able to make much progress here. You can see there was a slight decrease in numbers from 2023 to 2024, but HIV has been frustratingly resistant to kind of our efforts in preventing infections, despite some good tools that we have as far as HIV PrEP and HIV PEP and education. We're still not bending the curve, so to speak. Here you can see hepatitis A, B, and C, which are viral infections. We've grouped these together. You can see there's a big bump kind of midsummer here in 2025. It's primarily due to two testing events where we ended up diagnosing quite a few chronic hepatitis C cases. So the numbers, it looked like there was a big jump, but it was primarily from these two testing events. And really, you know, the numbers that we diagnosed weren't that high. It's primarily because I think primarily hepatitis C cases are being underreported. And so kind of any bolus of cases being entered in NCEDs, it looks like there's a big increase. There really wasn't, but we did have two pretty successful testing events and ended up linking a number of these folks to treatment. So you can see here, vaccine preventable diseases that 2025, and the figure is that slashed green line. We've had a lot of pertussis or whooping cough cases this year. And so that the increase you're seeing is it's almost all pertussis. And pertussis has been a problem, not just in Durham County this year, but statewide and nationwide. So we're seeing a lot of cases just like folks are elsewhere. And some of this is probably due to decreased vaccinations. Tdap, which prevents pertussis. The pertussis component tends to not, the protection tends to wane more quickly than with other vaccines. And so some of these cases are people that are up to date on their vaccines, but they've had breakthrough infections. But again, some of those cases are related to being exposed by someone who got pertussis that was not vaccinated. So vaccines still really crucial in preventing pertussis cases, but we have had some breakthrough infections as well. So vector-borne diseases, there's typically, we see an increase over the summer when people are outside and exposed to ticks and mosquitoes. Haven't really seen an increase in cases this year compared to prior years. You can see on the figure, ehrlichiosis, Lyme disease, Rocky Mountain spotted fever are all endemic. And then we do see malaria cases, dengue cases, those are imported. So people infected outside the United States and that were diagnosed here. Invasive group-based strep, we had been seeing an increase in cases the past couple of years. This year, cases have come down, thankfully. So we haven't seen as many cases as the previous 2 years. Waterborne diseases, we always tend to see a peak in the summer months when people are outside at picnics, getting together, and Campylobacter tends to be the most common cause of waterborne disease. Similarly, with foodborne illness, we tend to see increase in cases over the summer for similar reasons, and Salmonella tends to be the most common culprit. Not seeing really an increase in either waterborne or foodborne illness this year compared to prior years. And then respiratory diseases, tuberculosis, it's been a particularly busy year. We usually see 8 to 12 cases of active TB this year. We're up to 16 so far. So it's been the busiest year as far as active TB since I started here 4 years ago. Our data scientist, John Paul Zeta, predicted kind of for us, you know, how many cases of active and latent TB we would see at least through mid next year. And at least the data modeling is not showing any significant increase in cases, but it's been a busy year. And I just wanted to just highlight our TB nurses and our TB team. You know, you think of 16 cases, it may not seem like a lot. These cases are really, really time intensive. The treatment duration is typically 6 to 12 months. And it is the law in North Carolina that individuals with active TB need directly observed therapy during the week. And so our TB nurses are watching them take their medications Monday through Friday, every single one of these cases. And there's oftentimes these folks have complicated work schedules or kind of social circumstances. So these cases tend to be really time intensive. So I just wanted to highlight our TB team, especially in a year where we're really seeing a lot of TB. They do a lot of work behind the scenes, a lot of really good work. Flu and RSV, as far as wastewater surveillance, we've not seen any flu at our North Durham wastewater site. We have detected some flu at the South Durham wastewater site. We are just starting to see an increase in flu cases and presentations to the emergency department for flu-like illness. So we're finally seeing, I think we've hit the beginning of flu season. Not really seeing much RSV or COVID yet, but both RSV and COVID are certainly going to follow soon, and we'll start seeing an increase in cases as it happens every year around this time. Yeah, I already talked a bit about this. COVID still pretty low as far as wastewater. And then haven't had to talk about this over the previous 4 annual CD reports, but we did have 3 cases of neuroinvasive West Nile virus this year over the summer. And really a Herculean effort, primarily by Chris Salter from the Environmental Health Division, to get mosquito testing done in the neighborhood where we thought these mosquitoes were circulating, and then get contracts together for mosquito spraying. And so I wanted to call out Chris. He did a really good job kind of preventing more cases of neuroinvasive West Nile virus this summer, which can be really severe or deadly. So just in some good notes, we've seen a decrease in chlamydia, gonorrhea, and primary, secondary, and early latent syphilis this year. We've not seen a decrease in HIV cases, continuing to work on it. We've seen a lot of pertussis this year. And as far as respiratory diseases, starting to see an increase in flu with RSV and COVID, most likely to follow within the next few weeks as people get together for the holidays. And then we saw 3 cases of neuroinvasive West Nile virus, which was unique. I think our last case of neuroinvasive West Nile virus was in 2019, if I'm recalling correctly. So this is our CD team. So I want to thank Savannah. She analyzed this data and put the slides together, and JPZ, our data scientist, for helping out. And then this wonderful CD team who does a lot of wonderful work, most of it behind the scenes. But we couldn't do this without each and every one of them. So I want to thank them. And I'm happy to entertain any questions if there are any.
All right, I see a couple of hands. Dr. Silberman, Dr. Jackson. Did I see Dr. Orto as well? So in that order, Dr. Silberman, will give you the floor first.
Great, thank you. Is it Dr. Jenks?
Dr. Jenks, yeah.
Yeah, Dr. Jenks, thank you. That was a great presentation. I have 2 quick questions. First is, do you have any hypothesis about why the STIs are going down? Are people using condoms more, or are we having less sexual activity?
Yeah, it's a good question. I think the 2 most likely reasons are we're doing a better job screening and testing,
Okay.
Both in Durham County and nationwide. Particularly, I mean, so at the county, we screen everyone, but I think other places, I think particularly, are doing a better job screening younger people who are more sexually active and would tend to fall in those higher risk age cohorts. I think the other probable reason is doxycycline post-exposure prophylaxis, or DoxyPEP, which has been around for a couple of years. And so that's an intervention where for people that are most at risk for sexually transmitted infections, if they get prescribed doxycycline and they take it within 72 hours of condomless sex, that can decrease chlamydia and syphilis infections by 70 to 80% and gonorrhea infections by 40 to 50%. I do think that's playing a part in this. Now, there's some potential risks to doxypep. You know, are we promoting antimicrobial resistance? I think that, you know, there's surveillance being done with that, but I think that is having a very real positive effect.
Okay, and then
It's a
just
good
one other
question.
question, if I may. With the picking up diseases in the wastewater system, obviously we've had flu cases, but it's not being picked up. So what's the sort of concentration of cases you have to have before you start seeing it in the wastewater?
It's very small. It's parts per million. I don't have the exact answer for you, but it's very sensitive, and so you're correct. I mean, there's certainly been someone with flu that, you know, has a toilet connected to the North Durham wastewater system. Why, you know, it's just a sample, so it's not, I think it may be that the virus isn't in that sample, but so it's not perfect, but yes, from that sample, the test is extremely sensitive.
Okay, thank you. That helps me.
Yeah.
And Dr. Silberman, on that note, I'd like to publicly just thank the city of Durham for continuing to work with us, because there's one point in time we really had to fight to keep that surveillance going strong.
Yeah.
And we had to really explain that this is certainly public health and how we keep people safe.
Yeah, especially, you know, with COVID, when we don't have a lot of other tools now, and they've since started testing for other pathogens like measles, which is, you know, really handy. So
Great. Thank you so much.
sure.
Awesome. All right, Dr. Jackson, you have the floor.
Thank you, Dr. Jenks. I appreciate all of that data. And as a physician, it's always nice to see that and kind of compare that to the things that, you know, I see daily in clinic. So my question to you is regarding reporting, right? Because so much of the data and so much of the trends are really based upon what is reported and what we're able to track. What is your kind of idea in your, if you can estimate the percentage of folks that are actually consistently reporting these cases? How many cases might we be missing? Just kind of, if you can guesstimate what that might look like.
Yeah, I think it certainly depends on the pathogen. Like with waterborne diseases and foodborne diseases, most people that get as you know, get acute gastroenteritis, they don't go to the emergency department and get the multiplex GI pathogen panel done. And so we're missing a lot of Salmonella, Shigella, Campylobacter, those sorts of pathogens. They just never get diagnosed. Now, as far as when they're actually diagnosed, I think it kind of depends on what the protocol is. Is the lab reporting these? Are the physicians reporting these? And so I think it may depend on the institution and what's being done. Like with urgent care, you know, I would think that the onus falls on the provider, and that may not be done. Now, when we talk about tuberculosis, every single one of those, I mean, I'm confident every single one of those cases is getting reported. You know, we hear about the pertussis cases because it involves contact investigation. So I think it depends on the pathogen. HIV, you know, I don't think we're missing cases there. You know, I think, like mentioned, congenital syphilis, I think that gets a little tricky. You know, a newborn that's born to a mom with untreated syphilis and has negative testing, you know, they oftentimes will get treated because the testing can be falsely negative. Now so they may get treated, but that doesn't get reported as an actual case because the testing was negative. And so, you know, I think it just completely runs the gamut.
Okay, thank you. And I did have one follow-up question to that regarding, you know, kind of institutional policies on reporting, whether or not it's up to the provider or if the lab kind of automatically has some system, or if there's some connection with EMR, electronic medical record data. Are you aware of kind of what the larger, institutions like, you know, Duke, what are they doing?
I think Duke, the onus is on the lab, and I actually got an email from one of the Duke ID providers a couple weeks ago. He had seen a couple cases of salmonellosis in the hospital, and he was wondering if we were seeing increased cases. So we pulled the data from NCEDS, and I, showed it to him, aggregated, and said, no, this is pretty much what we usually expect. And he said, okay, I'll follow up with the lab and make sure that they're reporting these cases. So I think at Duke, the onus is on the lab. That's my understanding. Yeah.
Thank you very much.
Sure.
All right, Dr. Orto.
Yes, thank you, Dr. Jenks. Great report. I, along with many people at this meeting, I am sure, are pretty concerned about going forward with the changes in vaccination, what the plans might be with you and your team and all of us to make sure that we're watching closely, things like, measles and chickenpox and hepatitis and all those things. The increasing, decreasing. So do you guys talk about, the plans going forward with the vaccination changes and things that we may need to watch closer?
Well, yeah, I think, whenever we get a case reported of like chickenpox or varicella or pertussis, the entire CD team kind of rallies and we come up with a game plan. Who needs post-exposure prophylaxis? Which school nurse needs to be contacted so they can do kind of contact tracing. So I think we have a pretty good plan as far as those pathogens, the vaccine preventable pathogens, particularly in school age children. So I think
plans for prevention related to, big outbreaks.
So big outbreaks. Yeah, that's a good question. So I think we're ready. We did a measles tabletop exercise earlier this year, and we've had some internal meetings. Yeah, I think we're ready. Hopefully it's, the preparedness is not needed, but yeah, we're ready.
Yeah, just in case, because being the age that some of us have seen that. And so we just want to make sure that, and I know you guys are doing it, but it's good to hear about it.
Yeah, well, I mean, I just, read today, I think it's Spartanburg, South Carolina is having a big measles outbreak right now.
Yes.
And this is at the end of year where we've had outbreaks all over. So yeah, it's on our radar for sure.
Thank you.
And the only thing I'll add is I echo everything he says, but we also are going to benefit Dr. Orto and members of the board by the fact that with the recent move from North Carolina Department of Health and Human Services, you have it split. So you have some in Raleigh, but the most effective ones are Dr. Zach Moore and his team that are going to be newly relocated to RTP. So they're going to be really right in our backyard.
Okay, great.
So awesome. we are certainly happy about that.
Okay.
Very good. Very good.
Thank you, everyone. Happy holidays.
Thank you, Dr. Jenks. Once again, an outstanding presentation. But many thanks to you and your CD team for a very comprehensive report. We're going to move forward. We have our public health vacancy report, and I think Dr. Jenkins got that vacancy report under double digits once.
You talk about somebody who's proud, Dr. McDougall. Your last beat, and I could say,
yes, sir.
You got that bad boy in single digits.
Yeah, I love it.
But shout out to the leadership team. When we meet as a leadership team, this is the main thing we talk about: vacancies, what we can do to move along the process. We're certainly happy about our relationship with county HR and our representative from HR who helps us. But yeah, for October it was 9.7, and for we creeped up a little bit more for the next month in November at 10.1. But again, when you think about the fact that the county's vacancy rate overall is hovering 13-14%, we continue to do really well, but we want to continue to make sure that it hovers down. You're on mute, sir.
Sorry about that. Thank you, Dr. Jenkins. Our next report will come from Chris Salter, and that's our NOV report.
Yes, sir. Good evening. There's nothing really that stands out to me. It's pretty, normal report, but I would be I do think that it's worth mentioning that a couple of meetings ago, I don't think it was the last meeting, but the one before last, I mentioned one of our oldest NOVs, the 3913 Cheek Road property, was looking promising. We had established some better communication with the property owner, and he had agreed to apply with the city for connection to municipal sewer. So that was moving along really well. And in the meantime, he had to agree to pump and haul. So the septic system has to be pumped on a periodic level, and it's as needed. You can't set an interval because it's based on use. And unfortunately, the pumper that he's been working with has communicated to us that he's not been paying like he should, and he's been having to track this guy down and ask for payment and kind of pushing for payment. And so he's communicated to us that he will not pump the tank again unless he's prepaid. So we're monitoring the property a little more closely now, and unfortunately there is sewage on the ground and it looks pretty bad. So we may have to work with the turning the lot to move forward and take some legal action. So that's worth noting for the board.
Okay, thank you. Board members, do we have any questions for Mr. Salter? All right, well, thank you once again, Chris, for your reporting. Yes, sir. Our next report is our great health director. Dr. Jenkins will give you the floor for your health director's report.
Yes, sir. Good evening again to this great board. I'll be real brief in the essence of time. Always chock full of good information, this health director report is, but I'll just lift up Jasmine Sturdivant is our Region 5 tobacco control manager. There's some information in there, but she's off to a good start. As you may recall, December of 2020 is when Durham County took that position over from Guilford County. So we continue to lead the region and lead the way when it comes to tobacco control in prevention. The report also indicated that our great partnership with the Adams School of Dentistry has reached year 15. It's hard to believe, but we've been partnered contractually with them for 15 years. That relationship still goes strong. A little, I think Jim Harris can attest, every so often we have to have a meeting of the minds to make sure that things kind of get leveled out. But nevertheless, dentistry is still going well. We're doing a lot of pediatric dentistry and a lot of community events. So we are very grateful for that continued partnership. And certainly want to lift up our DINE team, the nutrition division under the leadership of Rachel Elledge. They are not sitting on their hands. They are continuing to be very active with the most recent pause in SNAP benefits with partnership from DSS. Big shout out to Deputy Director Liz Stevens, who was involved in making sure that we mobilize and we had a strong campaign to really address hunger in Durham during that particular time frame. I couldn't be more proud of us. Want to really lift up Kelly Warnock from the nutrition division as well. They coordinated, they campaigned. I know our agency within itself, we collected a lot of food, and we were able to help many Durhamites who were in need of food assistance during that time. It was a collective effort between Durham County and the city of Durham that got some headlines. So again, we continue to be very proud of the work that is being done with the DINE team and our nutrition division. Happy to answer any questions you may have.
I don't have a question. I just wanted to echo my pride really in not just I'm proud of all of the great work that the department is doing, but particularly with the DIME program, just consistent and outstanding efforts in nutritional education with our DPS, with our schools and the community at large, but especially with the suspension of SNAP benefits, the hunger relief efforts, particularly the Everyone Eats Durham program. It's outstanding. It makes me proud to say I'm a citizen of Durham and a member of this board when such great work is being done by particularly the DINE and Nutrition Division. So kudos. All right. If there are no other comments regarding the health director's report, I will we'll go on to our new business, which we have. We'll hear any agenda items or requests for agenda items for our February 12th meeting. I'll entertain those.
Mr. Chair, I may add that we will endeavor to have that February meeting to be an in-person meeting.
In person, yes, sir.
We will do our absolute best. Just had scheduling conflicts for this December meeting, but we look forward to it. I see you, Dr. Silberman. But we do want you all to convene, and we have an ambitious goal of introducing this illustrious board to our new mobile medical unit. We certainly want you all to step foot on it and see its beauty and see how it's going to make an impact to the Durham community. So we certainly want to make sure that you all know that that will be an in-person session.
Awesome. Okay. All right. Anybody else? Any topics you want to have covered at our February meeting? All right. Well, if there are no suggestions, we'll leave that to our health director and his fine staff to populate an agenda for us. We do have some committee items that we need to address. And the first of which is our nominating committee recommendations. And I'm going to give way to Dr. Miller to present those recommendations.
All right, thank you. And good evening, everyone. So the nominating committee, which is made up of Dr. McDougall, Josh Brown, and myself, have met and discussed the nominations for chair and vice chair for this upcoming year. We are recommending that Dr. Ray be nominated as chair and Dr. Jackson to be nominated as vice chair. Dr. McDougall, I'll turn it back over to you now for, I guess, discussions, motion, or voting on that for this evening. Thank you.
All right, thank you. Dr. Miller, I'm going to ask, as committee chair, you can actually make the motion for those nominations, and then we'll get a second, and we can go ahead and entertain discussion.
Thank you for clarity. I'd like to make a motion that we nominate Dr. Ray for chair and nominate Dr. Jackson for vice chair.
Thank you. So it's been properly moved. Do we have a second from the board?
Second.
Second.
All right. So properly moved and seconded. We're now ready for discussion if there is any. Any debate on those two recommendations? All right. Well, Don, I think we're ready for the vote, and we can vote for the slate in total. We don't have to vote for each office independently.
Okay, Dr. McDougall.
Yes.
Dr. Ray.
Yes.
Mr. Brown.
Yes.
Dr. Glover.
Yes.
Mr. Gregorio. Dr. Jackson.
Yes.
Dr. Miller.
Yes.
Dr. Orto.
Yes.
Dr. Silberman.
Yes.
Commissioner Valentine. And Dr. Verbeest.
All right. Well, congratulations to our newly elected officers for 2026, Dr. Ray and Dr. Jackson, our chair and vice chair, respectively. So again, our board is in very capable hands. I'm looking forward to serving under your leadership. Absolutely.
Thank you very much, Dr. McDougall. It's been a pleasure working with you the past 2 years as vice chair. You've set a high standard, but we will strive to continue that leadership.
And you will do even better, for sure. I'm looking forward to it.
And
so our next, Yeah, go ahead, Dr. Jackson. Yes,
Just
ma'am.
wanted to
Go
say
ahead.
thank you all for the nomination and the opportunity to serve. Look forward to helping the board continue its engagement and care and support of all the public health in Durham County.
Awesome. All right. Well, we have. I'm gonna let our newly elected chair-elect to present personnel committee, finance committee, and operating procedures committee appointments for
Yes.
2026.
Absolutely. Let me see if I can share my screen. All right, can you all see my screen? All
Yes,
right,
sir.
fantastic. So these are my proposed committee assignments. For the personnel committee, Dr. Jackson, who's the vice chair, is the chair of that committee. Mr. Brown, Dr. Verbeest, and Dr. McDougall. Would love for you to serve in that committee. For the finance committee, Dr. Jackson, again, as the vice chair, chairs that committee, as well as Dr. Silberman, Mr. Brown, and Mr. Gregorio. Operating procedures review committee, Dr. Orto, you've chaired that committee in the past, would appreciate your continued leadership there, along with Commissioner Valentine, Dr. Glover, and Dr. Silberman. And then for the nominating committee, Dr. Miller, if you would be willing to continue to chair that committee along with Dr. Verbeest and Dr. McDougall.
Absolutely. All right. Well, thank you, Dr. Ray. And I guess if there's anyone who has dissenting opinions about your appointments, you can email Dr. Ray privately, and he'll make adjustments. So, so we've talked about our agenda items for next month or for the next meeting. So we have a few moments for some informal discussion before we move to adjourn. Would anybody like to make any statements or ask any questions?
Dr. McDougall, if I may.
Certainly.
I just want you to know that although you're not here, we do have a plaque for you.
Oh.
On behalf of the very grateful board and public health department, I look forward to getting this to you, preferably over lunch.
Thank you,
like
sir.
we
Yep.
normally do. But
I look forward to it.
it reads, Board of Health presented to Roger McDougall, DDS, MS, Chairman, in appreciation for your dedication to Durham County Department of Public Health and the citizens of Durham County from January 2023 to January 2026. So we have this for you. We want to make sure that we get it to you, but I will take great care to make sure it gets to you.
Thank you,
so much.
sir. I look forward to the meeting. Yes, sir.
Indeed.
All right. Well, I will, before we accept the motion for adjournment, I will say thank you to everyone for your participation in the board. All of the board members, all of the staff members, Dr. Jenkins, you've made my job very easy, and I certainly appreciate it. I couldn't have done any of this without you. Donna, don't let me forget Donna, who's kept me in line for the past 2 years. So thank you so much, and I look forward to continuing to serve on this great board. And Merry Christmas and Happy New Year, Happy Hanukkah, Kwanzaa, whatever holiday you will observe over the next few weeks. Hope you enjoy and you have a safe holiday season, and we'll see you back next year. So at this time, I will entertain a motion to adjourn.
So moved.
Second.
All right, it's been moved and properly seconded. I don't think we have any unreadiness. So Donna, we will entertain that vote at this time.
Okay. Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown,
Yes.
Dr. Glover,
Yes.
Mr. Gregorio, Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Silberman,
Yes.
Commissioner Valentine, and Dr. Verbeest. Happy holidays to everyone.
Thank you. Happy holidays.
Happy
Happy
holidays.
holidays, everybody.